This morning. Okay, counties across the country are struggling to combat the public health crisis caused by the opioid epidemic. This session will explore the impacts of the epidemic and Aetna's efforts to provide successful strategies to address the issue. This is Dr. Barbara Ziv, and we welcome her today. She is the medical director with Aetna. She is currently the medical director for Aetna Behavioral Health. She joined Aetna in 2012 and previously was a medical director at Cigna for approximately 13 years. Dr. Ziv is a graduate of Wesleyan University and obtained her medical degree from Northwestern University Medical School. She completed her residency training in psychiatry at Cornell University New York Hospital and is board certified in psychiatry. Dr. Ziv is currently on faculty at Temple University School of Medicine, responsible for training residents in aspects of forensic psychiatry. She has extensive experience in the assessment and treatment of substance abuse. She has taught widely about issues including eating disorders, substance abuse disorders, and personality disorders. She has spoken at NACO in the past and also the Opioid Symposium in DeKalb County, Georgia, with very high reviews, and I hope you will welcome Dr. Ziv this morning. I'm having trouble talking, sorry. Thank you, Dr. Ziv.
So I have 5 kids, so I don't need a microphone because I know how to yell loud so that I can be heard. And I apologize for being sort of formal. This is not formal, and I want people to feel free to ask questions and interrupt and give their perspectives and whatever at any point. But I'm also going to stop at different points. So the issue of the opiate epidemic or the opioid epidemic, and when I was doing this PowerPoint, one of my colleagues said you use opiate and opioid interchangeably. Is that, shouldn't you be consistent? And I'm not being consistent because you will hear both words and they both mean the same thing. So if somebody says opioid and opiate, they mean the same thing. So I'm just going to start there. Now, every time I talk about the opiate epidemic, I am asked about how it begins. And I realized that we often jump right into the middle of talking about these numbers, about how many opioid overdoses there are, and how it's impacting communities, etc. And I don't think that most people really have an understanding, and this is true in the medical field as well, by the way, that unless you're specifically trained in the area of substance abuse or substance misuse or addiction, and all of those words are more or less interchangeable too, especially when we're talking about opioids. People don't know how it all happens and how it works and why it's so difficult. So I'm going to start with a little, with apologies to all of the, I was a liberal arts major, so, but for all the liberal arts majors who never took a science class, I apologize, but I'm going to give you a little bit of the biology of what goes on with opiates. Okay, so we're going to talk about addiction, the brain and opiates, what happens when you take these drugs, and how they lead to addiction. And we're going to talk about a national overview of what's going on and how it relates to prescriber behavior. All right, so when you go to these meetings, take away very few points. You know, you hear people talk. One of the points that I want you to remember is that the opiate epidemic started in the doctor's office. And I will tell you, it started in the doctor's office because when I trained in medical school, I graduated from medical school in 1987. I finished my residency in 1991. So for my class and the classes that followed, we were taught that pain was grossly undertreated, undermanaged, and we needed to open up our hearts to people who were in pain and to stop being so stingy with the opiates. Not surprisingly, the increase in opiate use began in 1999. So that's when my generation of physicians started practicing on their own. And we did that in response to a groundswell of research that said that we were undertreating pain. So opiate addiction. Now, I understand there has always been a problem with heroin addiction. There's always been a group of individuals who become addicted to street opiates. But the widespread nature that we see now, where it impacts working people, middle-aged individuals, everybody probably in this room knows somebody, or at least knows somebody who knows somebody, who's been impacted by that. That's why it has grabbed the attention of counties and the country. Because you can look at one group and say, it's not in my backyard. But it is in everybody's backyard right now. And that group of people that were not formerly addicts, that weren't even considered to be at risk for becoming addicts, became addicts for the most part, innocently, because they had a pain syndrome that was treated in a physician's office. So then I'm going to talk about what we're doing about intervening to address the issue, and tell you a little bit about the programs. Now, while I'm talking about Aetna's programs, and I think that Aetna's programs are more sophisticated than many other insurance company programs because we started early. We identified this as a problem before it reached the popular press in about 2012. So we have had a chance to look at the situation, tweak our understanding of it, try things that worked, try things that didn't work, and move forward. All right, so now we're getting to the biology. So there are two parts of the brain that are involved in opiate addiction. They're actually involved in all addictions, but we're just going to stick to opiates for right now. One is the cortex, which is the purple part of the brain right there. It's right here. It's what's responsible for thinking, for planning. It's also what's responsible for inhibition. So when you it is the latest to develop in the brain. It's the most robust part of our brain, and it's the most sensitive part of our brain. So this is not fully developed in little kids, right? So that's why a 3-year-old will have a tantrum when they don't get their needs met right away. When they want a cookie, they want it now, because the cerebral cortex is what teaches you to inhibit. So when that's not fully developed, you lack the ability to resist impulses. It is responsible for rational planning. So when we're talking about opiate abuse, and we're talking about therapy, this is the part of the brain that the therapy is working on. The therapy is working on improving those skills, improving problem-solving skills, improving ways to inhibit problematic behaviors that can lead to substance abuse. And to teach. This is the part of your brain that is responsible for learning and for regulating our behaviors. The limbic system. So as you go from front to back, you go from old brain to new brain. The limbic system, which is right in the center, is part of your old brain. You know, every primate has a limbic system. The limbic system is your basic urges, desires, pleasure, reward, those fundamental things that make us all drive towards something, toward a relationship, toward drugs, toward success, toward all of that. Now there are, of course, relationships between every part of the brain. So the cells of your brain are on the outside, and on the inside are the axons that are connecting. They're making all of these connections from the cortex to the limbic system and back again and everywhere else. So medication is what impacts the limbic system. So when we talk about treatment for substance abuse, specifically for opiate disorders, because that's what we're talking about, but for most substances, we need to have a bimodal approach. We have to treat the biology, which is the limbic system, and we also have to treat the psychology, which is the frontal cortex. So why do people become addicted? So the limbic system is also known colloquially as the reward center of the brain. It's the thing that makes us keep on doing what we want to do. It keeps us seeking pleasurable or reinforcing activity. So when you are eating something delicious, your limbic system is firing. When you are competing in a sport where you're not losing, when you're winning, your limbic system is firing. When you're learning something or accomplishing something, your limbic system is firing. When you are having sex, your limbic system is firing. Anything that feels good and is rewarding is regulated in the limbic system. Now, the neurotransmitter, the brain chemical that's involved in this, is something like an opiate. Everybody's heard of endorphins, right? So endorphins are naturally occurring opiate-like substances. So that's what everybody refers to when they say they got a runner's high. Or that's why it feels good when you're doing something pleasurable, because you're getting internal rewards. Your limbic system is getting these internal signals. They're getting endorphins, and they're also getting dopamine. So endorphins attach to what we call opiate receptors. Obviously, opiates are outside of the body. We should probably call them endorphin receptors, but we call them opiate receptors because in studies, that's what we find attaches to these things, these cells. So endorphins attach to the cells, and then the cells release dopamine. And then dopamine is the feel-good neurotransmitter, brain chemical.
Well, it means the indole ring is operating in the system.
Pardon me?
The indole ring that's associated with opiates operates within the system.
Yes.
Okay.
So what happens in addiction? So life would not go on, right, if your limbic system took charge and when you're doing something pleasurable, you could just keep on doing it, right? You would, and in fact, there are models of, animal studies that show that if you take out inhibition of the limbic system and you give rats something that's pleasurable like food or actually cocaine, that they will press that little button to the point of starvation and death. So this, as I said, is an old part of the brain. It doesn't want you only you know, to pursue pleasurable things. You have to do things that aren't so pleasurable, like, you know, do the laundry and, you know, go to work. So there is a down regulation. So when you get a lot of dopamine in there, it feels really good. But over time, that part of your brain becomes accustomed and down-regulates the receptors, right? Otherwise, we'd be all like that rat, just pursuing pleasurable things to the point of death. Don't pay too much attention to this little thing, but it was the only one that I could find. But so what happens is, you see those things that are attaching to the opiates? What happens is that there become fewer of those. They become desensitized to internal and external opiates. So what happens are two things. Number one, there is this learning that occurs. So when you have an increase in opiate activity and a consequential increase in dopamine activity, it feeds back to your cortex and says, this is important. This is good, this is pleasurable, this is rewarding. So now, you've learned to connect, I mean, unconsciously, your body has connected pleasure with opiate use. Because there's nothing else that's going on, right? It's not in response to an activity that has created a sport or an accomplishment. It's just as a result of having opiates. So what happens is that there is a down-regulation, so you need more and more and more and more opiates to get the same response. And in fact, because there's a down-regulation, you don't get the same response. But that's what happens with addiction, is that you have ever-escalating need physiologically to attain the same result. Ultimately, what happens in opiate addiction,
So it's sort of requiring more opioids. Because you've dulled, I guess, the experience, and so you need more and more. Are at the same time, are other pleasurable things dulled?
yes.
So if you get a runner's high and you're taking opioids, and now you need more and more opioids.
That's an excellent point. It's an excellent point. The short answer is yes. The longer answer is more complicated. Opiates also have a sedating effect too. That is in a different part of your brain. But yes, and I think that's an excellent point. That people. That's one of the reasons for decreased motivation and decreased pursuit of other things in people who have an opiate addiction.
Dr. Zeb, to add to what she's saying, and not contradicting anything you've already said, I've been on opioids since 2003 after turning back from Afghanistan and injured my back and neck. I've even gone all the procedures just short of surgery. It's still opioids, but I'm scaled down and got me down to tramadol, which was a waste. And I've had all the other things necessary. I'm in the pain management clinic. I've even gone and had the DNA test done to determine whether or not I'm predisposed to be addicted. It came back negative. Why aren't doctors pushing those DNA tests for patients to make them, I guess, to get a determination whether or not? Because what's happening, the people who need pain medication can't get it. And I have a terrible problem because I have constant pain. If I don't take the medicine, I don't take it all the time. I take it when I need it, when the pain is unbearable. But what that does, that transitions you from a nice person to a person who just sits on the sofa and eats and gains weight because you have no energy because of the pain. And then you still have the same problem. And I guess my question is, and my point is, why aren't insurance companies, I guess, working with pain management and GPs to get these patients to be tested to see if they're predisposed? I do realize, however, there always will be drugs on the street. You know, and that's something I think to me is worse than the people who are actually going to the doctors and trying to get pain medication. Because now you get it on 30 days and if the prescription isn't written exactly right, they won't fill it. And that's what I'm finding right now. And in my latest escapade with this, the doctor wrote my prescription for the medicine without the acetaminophen, and the insurance company wouldn't fill it because it's not on the formula. So I just had to suck it up. And people who really need it and legitimate can't get the treatment they need.
Well, you've raised about 75 points in that comment. And I'm only going to address a couple of them right now, and then a couple of them we're going to get to. Number one, the downregulation of opiate receptors occurs with addiction, with the chronic everyday use. The fact that you say that you go a couple of days without it, if you have a drug holiday, you're not going to develop the same tolerance that you do if you are an everyday user, number one. Number two, I'd like to know what drug test you took, because there is no specific drug test.
Well, it was they did a DNA sample out of the pain management, and the thing was that insurance didn't pay it, and this company that did it, I guess, was tested opioids, which is taken in as research.
Yeah.
Mine came back as negative.
Yeah, we don't have, if we did got it, would be, you know, we'd all.
I think it may be in its early stages of
Yeah,
doing this.
it would be considered.
Testing, maybe.
But there are, I don't want to get too far afield, there are genetic tests about drug responsiveness. They're not really well validated at all. And they don't predict better outcomes. So I don't know what specific test that you had. And the third issue, which is what about this chronic pain, we're going to talk about that, okay? So, but you do raise a good point. There are people who are on opiates, standing dose opiates, who do not increase their use over time. But I would argue that if you have a period of time where you're taking it as prescribed every day, that at the end of the 2 weeks, that it's less effective for you than it was at the beginning. So to get back to this, and the issue of pain management is central to this whole discussion, so we're going to talk about that. So the other thing that happens with chronic opiate use is not only are you teaching your brain, the thinking part of your brain, your cerebral cortex, that this is a good and pleasurable thing, but you're decreasing inhibition, which is why we see risky behaviors and behaviors that are out of character for somebody, because there's a physiologic disinhibition that's occurring from the cerebral cortex to the limbic system. This doesn't work.
It was reconnected a minute ago.
All right.
Here we go.
So then what happens, so now we know that there's this downregulation of opiate receptors, and you need more to get the same high. And I wanted to mention, by the way, that after a period of time, and it's not necessarily a particularly long period of time, you don't get the high anymore. You don't get the pleasure anymore. People continue to use drugs often because they don't want to get sick. Because the abrupt withdrawal of opiates can cause very uncomfortable withdrawal symptoms. So, and they're painful. They're not life-threatening. Going through a withdrawal from alcohol, if you're an alcoholic, can kill you, or a benzodiazepine. This won't kill you, but it's very uncomfortable, and people act in ways to avoid it, most often by using. So what you have is something called denervation supersensitivity. So you abruptly stop somebody from taking opiates, and now you have all of these exposed opiate receptors. You've shut down your own endogenous, internal opiates, and they're just out there like raw nerve endings. And you have early symptoms, which include muscle aches, tearing, runny nose, yawning, insomnia, anxiety, and sweating, and late symptoms. And these all occur usually within 72 hours. Nausea and vomiting, goosebumps, and that's why they call it going cold turkey, by the way, because of the goosebumps. Diarrhea, abdominal cramps, and dilated pupils. Because dopamine is not just in the limbic system, it's throughout the brain, and it's frankly throughout the body. So when you withdraw it, many organ systems are going to be involved. This is treated symptomatically. So you give medication for stomach upset, you give medication for aches and pains, what they're called myalgias. You treat it, you hydrate people, you treat it, you treat the symptoms. You're not going to go in and replenish the opiates, which you do, by the way, when you're going through alcohol withdrawal from benzodiazepines. It's an unpleasant experience. It often leads to people leaving early from treatment, but it's not life-threatening. And it usually resolves within 3 days. It can be 5 days. All right, so that's the biology of opiate addiction. Anybody have any other questions before we move to the next topic? All right, so I told you that opiate addiction in the population that we're seeing it in now starts at the doctor's office. Now, just to give you some idea of the scope, over the course since, I think, 2012 to the present, there have been 500,000 opiate deaths in the United States. And if you compare that to alcohol-related deaths, including motor vehicle deaths that involve alcohol, that's 100,000. So it's 5 times more than deaths related to alcohol abuse, which we consider to be much more common. So, usually it's one doctor prescribing. It's often a doctor prescribing for a long period of time. What happens is that individuals, as I've just told you, become sensitized to the medication. They become tolerant to the medication. And so they require more and more medication, which is often provided. So that's about 2/3 of individuals get their opiates from one doctor. There is a subset of individuals who doctor shop, who go to more than one doctor. We see it now, a huge increase in individuals going to the emergency room for pain medication because their doctors cut them off. There are other places. Dentists are the place where we're seeing more and more opiates be prescribed. Very few come from drug dealers, especially initially. So then I'm done with my, I had surgery and I was prescribed 10 days worth of Percocet. I only needed 3 days. My friend has chronic back pain. I say, I have all these Percocet here, take mine. I know that you're and so that's where most individuals go. that's the secondary process by which individuals, so, 50% of people who are not prescribed by a doctor will get it from a relative or friend. Other places, but this is typically after somebody's already addicted, get it from the street, from different doctors, even from the internet. So, deaths from heroin overdose. So I told you that, I finished my residency in 1991, and I was in the first wave of the new pain treatment revolution. So right after I began to practice on my own, along with my colleagues, you see a steady upturn in opiate deaths over the course of the years. All right, so here's what we know from our population of X million members. So the rate of long-acting opiate utilization has ranged between 34 to 37 prescriptions per thousand. Now, when I went to Georgia to talk to the counties there was a prescription written every month for every man, woman, and child in the state of Georgia, which is pretty remarkable. And that's a much more I couldn't find similar statistics in Virginia. But you can say 34 to 37 prescriptions per thousand. That doesn't sound like a lot. But when you look at it the way that it plays out in Georgia, which is there's a prescription written for every man, woman, and child every month. And I doubt that the numbers are much different in Virginia than they are in Georgia. A third of those prescribed opiates for chronic pain have a problem with addiction, meaning that they have increased their use, that their use is not controlling their pain, and they've developed tolerance. There is a huge risk in overdosing because the medications that we have are more potent now than the medications that we used to have. Morphine used to be a standard. The stuff that we have on the street, including OxyContin and fentanyl. And OxyContin can be written by prescription. Fentanyl is not. Fentanyl is either obtained illegally or actually made on the street. They are vastly more potent, and people don't recognize it, which is one of the reasons that we're seeing that's also contributing to the death from overdose. So, when you get opiates, so we're going to talk in a minute about what we're doing and what can be done to identify people who are at risk. One of the signs for somebody at risk for having opiate misuse or addiction is the use of both opiates and buprenorphine, which is also known as Suboxone. Suboxone is a good treatment for opiate addiction. It's a combination. The simple way to put it is that it acts on those opiate receptors, but it neither stimulates them nor blocks them. It just sits there, and it doesn't give you a high, and it doesn't put you into withdrawal. Provider underutilization, we'll talk about that. So let's talk about what's happening in your neck of the country. In 2016, and I pinched this from your governor's website, so there were 1,268 overdoses, fatal overdoses. The region of highest mortality for prescription overdoses occurred in, which is excluding fentanyl, which is not prescription. in southwestern Virginia, the highest mortality for heroin and fentanyl, which both are illegal medications, occur in urban areas, and that probably doesn't surprise anybody. In 2015 and 16, fentanyl and heroin were the leading causes of overdoses, especially because they get combined, and fentanyl is an extremely powerful, potent narcotic, opiate, and it's used. The reason it's in anybody's formularies is because it's used in anesthesia. Okay, we have another. So you have about 500 people who, per 100,000, who are discharged from the hospital. These are non-fatal overdoses. So the rates of overdoses is far higher than the rates of deaths from overdose because people seek treatment or their friends bring them in. But there are other things that we don't, that are less well publicized. Neonatal abstinence syndrome, meaning kids who are born to opiate addicted mothers, is a big problem.
How is that different from a substance exposed infant? Is
What?
this specific to opioid?
No. I mean, no. It is a subset of a substance exposed. In utero exposure to various substances causes different problems. If you're exposed to alcohol in the uterus, you can develop fetal alcohol syndrome. If you are exposed to cocaine, you can have heart problems. If you're exposed to opiates, luckily it's not going to cause developmental problems, but the infant is going to go into withdrawal and need to be treated with morphine or an opiate when they're born for a period of time. It can lead to respiratory depression and death in infants if it's not recognized. And the rates of hepatitis C, which is really coming from intravenous drug use, fentanyl and heroin, is high, 86 per 100,000. All right, so here it is from your governor's website on the map. So in 2006, there were 803 fentanyl, heroin overdoses, 465, 1,400 ER visits for heroin. So, over 10,000 ER visits for overdose that are not fatal. Narcan is administered in about half of those, or almost half of those. And there is this alarming number of new cases of hepatitis C. Now, hepatitis C is a potentially fatal liver disease, and seeing that there are 2,000 new cases, in 18 to 30-year-olds is extremely alarming. So, you can see this on your...
Could I make a comment?
Sure.
That you can drill this down to localities or regions. Go to vdh.virginia.gov, and then up at the top there's something that says data, and we have a lot of open data, but you can pull this and you can look at your own region or locality much more specifically.
Yeah, I gave a shout out to the government on this. I got it, pinched it from the website. Okay, so what are we doing about prevention? Because really, prevention is the key to dealing with this opiate crisis. Well, there are two parts. We have to address preventing new addiction from developing, and we also have to address the people who are already addicted. And they are really two different things, because if you take somebody who's already addicted and a doctor cuts off their prescription, what they do is they go to the street, or they go to real extremes, including engaging in self-injurious behavior so that they can go to an ER and get pain meds. So we're talking about two different things. When we're talking about preventing for future use, we really have to stop it with at the doctor's office, to identify people who are at high risk, to inform physicians about opiate prescribing practices through national data banks. In different states, you're required now to document, to register every time you write prescription opiate abuse. At Aetna, we are monitoring every individual's prescription opiates. We are monitoring whether they are getting them from multiple providers, whether they're getting multiple prescriptions from the same provider. We're monitoring whether they're getting multiple classes of an opiate medication. And we're not just sending out a letter to the provider, even though we are sending out letters to providers, but we're not just doing that. We are contacting these individuals directly with a variety of programs, which I'll talk to you about in a little while. Because you can't just rely upon busy providers to be the only source of intervention. But we're identifying these people through claims data and being proactive in identifying them and getting them into substance abuse treatment. We are also working with government agencies and community agencies in the campaign to change direction. And we're increasing awareness. And along with increasing awareness, we have to discuss decreasing the stigmatization. Stigma is still probably the #1 barrier for individuals to seek treatment. Especially, as I said before, when we're talking about a group of people who aren't the people who, were the heroin abusers of the 1970s. These are people who are professionals, who have families, who work. And it is the #1 barrier to seeking treatment. Are very active in addressing the issue of stigmatization. I'm very fond of saying the brain is part of the body. You wouldn't be embarrassed if you had diabetes or if you got diagnosed with hypertension. But somehow it's still shaming that your body becomes addicted to medication. So we use all aspects of our resources at Aetna, because this is a multimodal, you need a multimodal response. You need to address the physicians who are prescribing the pain medication. You need to offer alternatives, and insurance companies need to pay for those alternatives, to pay for acupuncture, which we do, to pay for biofeedback, which we do. There has been too little focus on alternative on pain management strategies. So you have to address the medical side of the issue. You also have to address the behavioral health side, because behavioral health is what manages the treatment, and behavioral health is what manages both the beginning of treatment, which is often detox, subsequent treatment, which may be residential, partial, IOP, outpatient, and ongoing care. There are very long-standing studies, long before the opiate crisis hit the news, about what the most effective treatment, where the most effective treatment for long-term sobriety takes place, and they tried every which way. They tried assigning specific people to specific programs. They tried to do motivational there are lots of different ways that they approached it. The one thing that came out of all of these long-term, multi-center studies was that the number one thing that will prevent relapse is continued treatment. So the longer somebody is in treatment, and that doesn't mean, you know, seeing a doctor every day, it's the sort of AA model, you know, when you have somebody with 30 years of sobriety who says, I am an addict. So we provide outreach on an ongoing way to members, one-on-one. We have a very robust care management program. When somebody is identified at risk, we have a care manager reach out to them, and that's their point person going forward. We also have programs for individuals who don't want to receive calls. We have a program called Able To, and I think I'm going to get to that soon, but where it's computer-based. We have phone-based, text-based. We have multimodal ways to respond to individuals with substance abuse, because we know that the most effective way to treat somebody long-term is to have continued contact, not just to deal with them when they're in crisis, having OD or having just completed a detox.
I have a question. How long do you allow them to have the treatments? How long, you know, a period of time that they're able to have the treatments for any of this?
There is no mandated number. You know, for women who are identified as an opiate addict while pregnant, we identified them, and that group is mandated. We are mandated to follow them for a year after the birth of their child. So some of these programs, they go on for a long period of time, where somebody has, and it's not just 9 to 5, Monday through Friday. These programs that we have are 24/7, that somebody can be reached, you know, and that there is outreach. So the first line of treatment for an overdose is Narcan. Does everybody know what Narcan is? Narcan and Naloxone, it reverses, unlike Suboxone, which sits on a receptor. Narcan locks, kicks out the opiate from the receptor. It puts you into immediate withdrawal, but it also saves your life. Narcan is delivered 2 ways. It can be either delivered by injection, either into a muscle or under the skin, or there's a nasal spray. You in Virginia may all be aware of your program, Revive, which provides training and recognition of opiate overdoses, authorizes pharmacists to dispense naloxone and coordinates with the Virginia Drug Control Act, which means, my understanding is that it applies to the population, not to an individual. So pharmacists can give you a pack of 2, either injectable or nasal spray, naloxone. But it is not free. Aetna would pay, if you have Aetna insurance, we pay for it. But it's not paid for by the state. But you don't have to wait for it, you can go in and get it. One of the, I brought up the issue of stigma. People are concerned about that. When you get this naloxone from your pharmacist, you're going to be entered into a database. Now, we do have HIPAA rules, etc. But we do everything that we can to decrease the stigma. So if somebody doesn't go and get their own naloxone, the state of Pennsylvania, Aetna provided every police unit in the state with naloxone to treat overdoses. So the number one issue that we're addressing is prevention, but we also have to intervene and treat, and then follow people into recovery. Because as I said, recovery is not a 1 month, 2 month thing. It's not like recovering from a broken bone. Yeah?
With reference to the intervention or actually treatment, I guess, and I'm talking about the overdose, the apparent overdose with Narcan. One of the things we're seeing trending is, I think most people would think that if you had come close to dying and somebody had to give you Narcan, that would be a life-changing event. What we're seeing is that if the people in that area find out somebody has overdosed on it, then it's even more desirable to find that drug. And that now they're taking the game, I call it a game, but I know it's not. I just don't know how to, because I'm not an addict. What they do now is they find the really strong fentanyl laced, they overdose on it, and they have their friend there with their Narcan to bring them back, and that's achieving some new level of,
Craziness.
yes. So it seems like to me as much as we're trying to do this very responsibly, that it's not having the desired effect. Particularly, I know you were talking about different, and I think you're spot on talking about people that are on prescription meds and that kind of stuff. And I'm obviously talking about street drugs. It's a whole other game when it comes to them. The Narcan, you go grab the newest and the best that just overdosed somebody down the street, you grab your Narcan and a friend, and you go have a good time, and it's just ludicrous. And when you mentioned the database, because that was brought up earlier, said, I wonder if we're even tracking this. Isn't it ironic that we track, and I understand why we do, when we track when I go buy Sudafed, they'll track me when I bought Sudafed, but we're not tracking Narcan to see what the problems are, where the areas are, and that kind of stuff.
I think that will come, but the truth is that Narcan does save lives. And you're right. You put it out there and it's going to be abused. You're going to find some way, some group of people are going to find some way to abuse it. No question. The same thing is true with Suboxone. Suboxone you can't get high off of, but people use it as a substance of abuse,
I didn't know, I know it's hard to answer, but it's just, a lot of people think this is cut and dry.
It isn't cut and dry.
Like hitting a moving target.
It is not cut and dry, and you're absolutely right. You put something out there, and, there's going to be a certain percentage that are going to find a way to abuse it. But overall, Narcan does save lives.
Can you address, or do you want to address the fact that often when you use Narcan on someone who's OD, they come out very violent? And, is there a reason for that, or do you not even want to address it?
Yeah, it's because you've taken them off of, you've knocked out all of the opiates from their receptors. So they've got nothing in there to modulate their response. So they're hypersensitive, and they can be aggressive. I mean, they're not coming off of it slowly. 100% is gone. It's not like it's metabolized over time. So yeah, they can become aggressive. And another thing that you guys also need to be aware of is, again, like everything, so what happens when somebody goes through detox, and then maybe rehab, and then maybe partial, and then maybe IOP, and they've got 3 months of sobriety under their belt? What happens to those folks? They've decreased their tolerance, right? Their brain has sort of returned to normal, even though there's some debate about how long it takes, but they certainly have decreased it from where they are. They go back and they use it the same rate that they were before, or the same dosage that they were before. That didn't do anything, and now they're overdose.
Well, he was mentioned, I don't mean to object, but he was mentioning a good point, and that is people that are trained in the use of Narcan know that, particularly if you're dealing with somebody who is an addict, I know it's hard to identify that, but we just bring them up to where the respiratory rate is good and we can manage the patient. We try not to bring them all the way out. And we talk about doing nebulized Narcan and things like that for those people who are chronic users. But it is one of the things you have to consider. We hand these things out being responsible to citizens or police officers or whoever that may have a certain level of training, but you're exactly right. They completely put them into detox, if you will, and now you're dealing with a combative patient that's just basically...
It's sort of like this, I don't know how many of you have had surgery or have seen somebody come out of surgery. The same thing happens there. People when they're waking up from surgery. It's the same sort of thing, that they're disoriented and they're violent and they can be aggressive and disoriented. It's the same phenomenon.
Thank you.
All right. So what we are doing is we're trying to identify people who are at risk or who are already addicted to opiates. The best way to do that is through pharmacy data. So we all members have pharmacy. First of all, one of the unique things about Aetna is that it's a continuous program. There's no wall between behavioral health, medical, pregnancy, OB, and pharmacy. So we have access to all of this data. We're not siloed, which is a big deal. So I can get this data on a back pain patient or a fibromyalgia patient. I just look at the pharmacy data. So we have, so one of the issues, so first of all, we need to identify people who have multiple prescriptions, who are prescribed by multiple providers, who are on more than one, or who are on for a prolonged period of time for a non-indicated use. Of opiates to treat pain, only 20% of opiates used chronically are to treat cancer pain. And cancer pain is really one of the few indications where long-term opiate use is indicated. But 80% of the people who are being treated for pain are being treated for conditions other than cancer. So we look at all of those measures, and we also look at fraud and prevention through the SICU. There is such a thing as pill mills, no doubt about it. There are doctors who take cash and who prescribe both illegally and immorally. We also find that there are facilities that engage in unethical and illegal behavior, especially there are facilities in Florida and California. Those are the two big hot spots where people are hired to go on the street and to fly somebody out of their Philadelphia neighborhood down to a treatment program. And there's a lot of questionable activity, including drug selling on site, etc. So we have a very active investigation into providers and or facilities that engage in illegal behavior or behavior that is certainly not in the best interest of the individual. We have recently developed formulary guidelines. For example, if you are a dentist, you are not allowed to prescribe more than 7 days of an opiate without a review. If you are prescribed long-term opiates or certain classes of opiates, we review those all. It used to be that pharmacy claims were not reviewed. We now review all requests for certain classes of opiates, and certainly for duration of opiates, they are reviewed by a pharmacist and or a medical director. We have, as I said, we have eliminated co-pays for medication-assisted treatment, which is shown to be very effective in treating addiction. We have we've already talked about a Narcan prescription. It is part of our policy now for everybody who is being discharged from a substance abuse treatment facility when they have an opiate diagnosis to do a screening for risk for overdose. And we counsel the facility about prescribing Narcan. And in terms of treatment, now, I assume, dismal outcome for traditional treatment models of opiate use. Anyone want to hazard a guess what percentage of individuals will relapse within a year after treatment?
90.
Exactly. It is a chronically relapsing illness. We do not, and that is true whether you're in the United States and you are treated at a 30-day program, or whether you are in Great Britain or Australia that have year-long programs. It is true regardless of the length of the program. The only thing that is going to change that number is ongoing intervention.
What was the percentage, ma'am?
90%. It's a dreadful illness, and it is a life-destroying illness. I mean, if you don't die from overdose, it's a chronically relapsing illness.
Because why wouldn't, while you're fixing that, why wouldn't the doses for like a wisdom teeth, I know you said that the insurance companies or PBM are cutting it back to a dose of 7 days, but why wouldn't it be like 5 days or less? The reason being is I read some statistic that anybody that takes an opiate for 5 consecutive days then becomes 50% more likely to have some form of addiction. So I'm thinking, why wouldn't they tie together that stat with a 5-day supply instead of pushing it to even a 7?
Well, that's a very interesting question. And in fact, my husband, who is a pediatric ear, nose, and throat surgeon, and I had this debate 2 days ago because he prescribes a week for opiates for tonsillectomy for children. And I said to him, why do you do that? 5 days is plenty. And in fact, probably more than plenty. There are many reasons to do that. First of all, we at Aetna go by evidence-based guidelines. We don't make decisions because it sounds good to us. Until there is good literature to support a decision, and the guidelines now say 7 days. The assumption is, all right, so a part of that is, so then what happens to that unused medication? You know, we need to partner with individuals, with physicians, with pharmacies to get those medications back so that they are not abused by somebody in the family. So my husband prescribes a 7-day supply to a kid with a TNA. The kid is, you know, doesn't get any of it because the mom takes it. You know, it's an issue. So we can't be cavalier about having these things circulate in the community like aspirin. Well, aspirin doesn't circulate anymore, but like Tylenol. Yep.
How do we compare with other countries? I've heard numbers that, you know, the United States prescribes way more opioids or any kind of PEMIC than other countries do.
Yes.
around the world.
Yes.
And why is that, if that's true?
That question is so wide and so deep and so tall. I mean, why do we have a GDP, I mean, our per capita spend on medical care that is, you know, 50 times that of any other country. I think it has to do a lot with our attitudes as patients about what we expect. And I think it goes hand in hand with the fact that we do have this huge number. I mean, the percentage of our GDP that's related to medical costs is just astronomical, and it makes no sense because we don't have better medical outcomes than most countries in the developed world. But I do think it has to do with a cultural norm in this country that expects that, you know, people expect to go to the doctor and come out with a prescription. We expect you know, not to be told no. I think it's a cultural thing. And I also think it's related to the overutilization of medical procedures and medical intervention overall in this country. But yeah, we're higher, a lot higher. One of the things that we are doing is, you know, along with what you just said about, we don't do DNA screening, but we are actively working with primary care providers. So 50% of opiates are prescribed in the primary care setting. And so that's where most people are getting their medication. And primary care providers are going to be more aware of it, but they certainly have not, to date, had to keep track of the opiate prescriptions that they write. So we're working with primary care providers. We're identifying preferred providers to make sure that individuals get screened for opiate misuse or abuse, along with, you know, opiate abuse isn't the only thing that we're looking at. Obviously, we look at other substances for abuse too. We have are very active in using medication-assisted treatment for substance abuse, and we don't, as I said, we don't charge a copay for Suboxone anymore. And we are expanding value-based contracting, meaning that we're identifying providers that do a good job, that work well, and have good outcomes for their patients. Now, I told you, it says future state. I actually made these slides a while ago. We actually have this now. Able to is substance abuse coaching. That you don't have to leave your house. You can get it on your phone. You can get it on your computer. It's and we also offer cognitive behavioral therapy, and we offer CAT-Assist, which is 32 weeks of coaching with medication-assisted treatment. So that's a year of coaching, right? You ask how long we stay with you. We stay with you. Well, we will stay with you because that's when things are going to change. We also have, you know, along with the AA model, we're very, you know, the literature is really strong about the fact that AA has stuck around and is effective. If you want to look at any of the studies, I don't care what treatment facility you talk to, they will not have as good, robust results in terms of, no matter how you measure it. If you measure it by sobriety, by decreased heavy drinking days, by number of days of abstinence, AA does the best job. And why do they do the best job? They're all peer, but they're long-term, and they recognize it. They recognize it as a long-term, lifelong process. So we are involved in programs using peer support in addition to counseling. Now, we keep somebody, so somebody has a substance abuse problem at Aetna. They're assigned a case manager. That case manager, that's different than a utilization manager. That person is going to call you, talk to you, do some screening tools, and that person's available to you. So we have a very strong case management program. We are also involved, you know, we're both involved in legislation. We're involved in partnership with various organizations. And we're involved in looking at research about alternative pain management techniques, which I think is the key. We were a founding member for a campaign to change directions, which is basically an educational program to identify individuals who are at risk for substance abuse, who are maybe using substances. And we have so many programs that I could probably talk to you for 2 hours about the different kinds of programs, because we realize that people have different needs. That some people need face-to-face, some people can't do face-to-face, some people, especially people with chronic pain, you know, may be immobilized, and so the better way to reach them is via computer. So we have myriad programs for addressing this issue. All right, so,
Could you read what the 5 signs are there?
yeah, it says, they're basically the 5 signs, and you can look them up on the website, but they're basically signs that somebody may have a substance abuse problem. So is there a personality change? Are people more irritable? Are they more isolated? Are they staying to themselves more? And are they engaging in risky behaviors? So, but there's a whole program that you can access on the Aetna website about this. Anybody have any? Yep.
As far as education goes, how does that open into schools, especially at young ages, to maybe program that from elementary all the way to high school to educate? I mean, I know probably my kids are grown, I have grandkids now, but I don't want to get involved in the school. It seems like that may be an approach, you know, to educate people about drug use. I know they probably teach it, but how much of an impact could insurance companies have with educational systems through the Commonwealth across the nation?
I think that's a good point. I think that, you know, that there certainly has been their impact of students against drunk driving, for example.
Right.
And I think that that is, I don't know of any current initiatives that we have actually going into the schools, or we may or may not, I just don't know about it. But it does have an impact, especially when it's peer on peer. And elementary school's not usually the right place, because I don't think that they have the cognitive capacity to get it. High schools have been shown to be a very good place for disseminating information about risky behaviors and about ways to intervene. I mean, I have kids too. My kids are, you know, in their 20s now. But all throughout high school, nobody ever let anybody drive and drunk. Nobody. I mean, you know, the whole issue about in college and beyond, it helps, but there's always been, and I think that that's in great part to improve education in the high schools.
Just to add to this gentleman's comment, Aetna recently entered into an exclusive arrangement with the National School Boards Association, which consists of 70,000 school boards across the country. Dr. Ziv doesn't know this yet, but we're going to invite her to come speak at their annual conference, at her own educational workshop, to your point, to talk about this issue. As I understand it, they are all salivating to hear more and learn more. So that's one way we're trying to help.
Thank you very much. Before you leave, I would like to remind you the evaluation forms are in the back of the room. If you would be kind enough to fill that out, that would be very valuable to Breakout. Are there any other questions?
Is there any sort of approach to the insurance companies, doctors, and the pharmaceutical companies, because they're the ones that make all the money off of it?
Yeah.
Well, to search for a different type of drug or something that affects the system.
Yeah, actually.
But with those completing that indoor range, it's high.
We have tweaked our pharmacy benefits so that we don't authorize certain classes of narcotic medications unless there is a specific exception made and it has to be reviewed by a medical director. So yes, we are working with pharmacies, and actually we're directly, as you have read, but even before the whole thing about CVS and Aetna, we've been working with CVS Pharmacy to address this situation. So yeah, we do.
So I would like to thank Aetna and thank you to Dr.